vascular access in bleeding and trauma patients. And I want our panel to introduce themselves, what they are doing, where they are from, and so on. Please go on.
My name is Per Skog. I'm a vascular and endovascular surgeon from Gothenburg, Sweden.
My name is Martin Delle, and I'm an interventional radiologist working at Karolinska University Hospital Huddinge in Stockholm.
My name is Taudorf. I'm an interventional radiologist in Athens, Greece.
My name is Seppo Hiipola. I'm anesthesiologist from Helsinki, Meilahti Hospital.
My name is Daniel Eefting. I'm a vascular surgeon from The Hague, the Netherlands.
My name is Patrick Vriends. I'm a vascular surgeon from Tilburg, the Netherlands, Level 1 Trauma Center.
Thank you, and go on, Thomas.
Yeah, we give you a warm welcome. Maybe we can start with a short question. I'm always interested. Maybe we can see what is the audience like. Maybe who is a vascular surgeon can lift the hands. Radiologists. Oh, even some. Anesthesiologists. Surgeons. No, oh, yeah, some. And trauma surgeons. Okay, so. Okay, that is, I think, very helpful. I think we should start.
Yeah, I think it's all groups are well represented, and I think we can kick off with the first presentation. And our first speaker will be Soran Rancic, a friend to me, and we have worked together a lot about aortic aneurysm. Soran is from Zurich. Please take the floor. Push the button.
Is it okay? Okay. Good morning, everybody. Thank you, Thomas. I'm really happy to be here with you and to share our experience. And I'm feeling really good with Thomas, Tal, and your guys here. So I'm coming from Zurich, and I have nothing to disclose. And our experience of the use of resuscitation balloon is based on our rupture cases. From 1997 to 2016, in total we treated 361 patients with ruptured AAA, out of them 215. We started endovascular program of ruptured AAA in 1998, and thereafter we, from feasibility, moved to intention to treat, published first time in 2002 when we also showed to use a balloon. And as you can see, we are playing with two balloons, not one balloon, then playing with the two balloons. And out of all the patients treated endovascular, we are using that in 70% of the cases. So that means we have to, in a patient with unstable hemodynamics, when we lose the consciousness of the patient, we use the transfemoral balloon technique. We're using a sheet, 12-French sheet, 45 centimeter long with compliant balloon, and then supported how to take the balloon into position not to slip down. A short period of visceral ischemia, but we know we have better coronary cerebral circulation, we diminish blood loss, retroperitoneal hematoma. This is what we can expect that everyone has to have. Know that there is possible embolization using a balloon because of the shaggy aorta, because of the thrombus. We can make a femoral artery rupture, dissection, balloon rupture, balloon can be dislocated, and don't forget ischemia reperfusion syndrome. The most frequently used access is the femoral access, open and percutaneous. Per string fascia closure promoted by Thomas Larsson and our surgical technique for open surgery. That means cut down femoral. I heard yesterday there is not, people are not feeling confident how to use this, the way how we did it. That means 2 stitches, plaque-free location, intimal fixation, not tear out, puncture the artery with the open Seldinger technique, then put a wire. We can use up to the 24 French sheet. At the end, when we're removing the sheets, we can close it, and in case of bleeding with an additional suture, when you can close the access hole. Nowadays, these techniques are less in use, and this is in time when we mix two techniques. On one side, we are using open surgical access. On the right side, and you can see here using percutaneous access. Nowadays, we are using always percutaneous access. What is important in the beginning to identify potential troubles of CTA. Don't proceed to put a balloon if you don't where you are putting this. Looking for calcification, arteriomal stenosis, and we are doing that always with interventional radiologists. Normally, as a normal EVAR, for us is rupture EVAR, normal EVAR in some specific stress situation. We are trying to do this with ultrasound, we puncture always 2 centimeters above the femoral bifurcation, and we try to put in that moment also pre-close device. What is the benefit? What is the complication? In case that we have a failure at the end of when we want to close the access sign and we have a bleeding, in that case we can put a balloon in the external artery, for example, and then put a stent. What I want to stress out is the use of this high proximal access 2 centimeters above the femoral bifurcation. At the moment we are accessing the artery, and when we want to put a balloon, we are focused on that problem. But thereafter, we can have a problem to close this vascular access. So we are puncturing always 2 centimeters above femoral bifurcation. So in case that we have problems to close the suture site, and there is a constant bleeding, we can put through the wire, we have that, we can end on clamp, and then below we are making a second distal access, putting a wire, putting a stent band, and the end close the whole procedure with the ProGlide. This is how it looks like. Re-access from femoral, then balloon, and put a stent. If we have a tortuous arteries, what we see during the CT scan, then put one wire, put a second wire, and as Benjamin Starr said, yes, use the straightened iliac artery, but in case that the both are tortuous, then we need the both wires to stabilize our sheet. Without this sheet, and sheet can damage the artery if we don't have 2 body wires into iliac arteries. Femoral access is one, but there is the others. The first described is the upper extremity access, 77, and this is transbrachial access done by one Swiss colleague, Professor Narbut from Berg. He made his own catheter. It was like 4 centimeter catheter, and then he showed the improvement of after deploying of this balloon for control, and the mortality in 2 groups was very different, 25 in the case when he used balloon for remote control. And he also stressed that there is a balloon catheter, bad quality, and there was also assessment problem. In this, we are also using sometimes transaxial access. As you can see in this patient, put a transaxillary balloon to obtain a control, and after 2 minutes and 45 seconds we stabilized the patient. Transaxillary access with suprarenal clamping makes rupture EVAR with parallel grafts inappropriate. You know, we are using a lot of chimney periscope grafts to make more rupture EVAR feasible to endovascular mean, and in this case, if we want to put it transfemoral, we cannot make parallel grafts to this patient. So we decided to make this patient open after putting transaxillary access on obtaining bleeding control. We open the abdomen, make the anastomosis proximal, then distal clamp, make bypass to left renal artery. That means just renal aneurysm was treated. Also, we don't, sometimes we have occluded arteries, we make suprainguinal or retroparental vascular access to address this. So, ladies and gentlemen, I want to stress out everything to use vascular access for treatment and to put a balloon should be patient-tailored, having in mind what is the benefit, what is the bad things, and to try to find a balance between risk, complication, and benefit. I have 21 seconds, and I want to put one topic that is what about the simulation for REBOA for even in rupture cases, and this is something we can simulate using of this balloon, how to make endoclamping, how to try to use 2 balloons in technique when we want to learn this. So simulation should be also the part maybe for the next REBOA meetings to say how we can simulate to use a balloon in the rupture case. Once again, thank you very much for your kind possibility to be with you today.
Thank you, Soran. Thank you for a real nice and presentation with a lot of innovation as usual. Any questions from the panel or the audience? Okay, Stavros, please.
Yeah, just I would like to remind that sometimes the bifurcation of the femoral artery is too high. So it would be nice just to have a CT and see if you have a high bifurcation. So the 2 centimeters above the bifurcation might be in the external iliac artery sometimes. So if you don't have a CT, just you can see the femoral artery diving into with your ultrasound if it's too high. Or the other way to do it is just a tiny fluoro and see where you are, your level of puncture. I mean, that's the way not to miss it and just to puncture the right spot.
I don't know if it was a comment or question, but if it was, I will comment also. The point is, whenever we are doing rupture AAA, we need a CT scan. So this time that we are making after clinical decision, after ultrasound is completely finished. So that means also in an unstable position, our organization room, emergency room is like this, then our CT scan is within the emergency room. So we have possibility to proceed to the CT scan in the case that the patient deteriorate. We have ERBOA set for endoclamping within the emergency room, and this means this is also within the CT scan. So I think without CT scan to make rupture AAA is not going to work nowadays.
A short comment, Soran. I want to hear your opinion about this. By intention, you have, so to say, a high puncture, though within so to say, IFU, in order to have the possibility to put in a stent graft in the groin to cover the leakage. So that is a bit, I mean, that's not the normal way we do it. Any comments from the panel about that strategy? Per?
The most stent grafts in the groin I've seen was occluded.
But how I will say, that's why we say 2 centimeters above. If we puncture the artery, initially puncture it 2 centimeters above, we have enough landing zone to deploy it distally, so don't to cover profunda femoral artery. And what is also important, we are done outside of this stress situation. That means we fix the bleeding, we fix the rupture by an endovascular means, and we are now in the relaxing phase to complete the procedure, and then we have time also to do. And also what is important with this technique, we can also go through we can puncture the stent graft.
Just a short question, we have 20 seconds. Give me the number of the percentage you need to fix with the stent graft from inside after using a ProGlide. Give me the number.
Let's say 5%.
5%. Okay, thank you. I think we are ready for the next speaker. Thank you, Soran. And I want to introduce Jan Holst from Malmö. Yeah.
He's coming along. Just give my. I have 7 minutes to talk first. Okay.
Thank you. Vascular surgeon, please.
Thank you. There are 2 obvious prerequisites. You have to know the anatomy, and you have to know the endovascular equipment. This is obvious. However, this is a potentially very chaotic situation, as we all know. And if you don't know your anatomy, and if you don't know the endovascular equipment, things can get pretty messy and quick and have a lethal outcome. What we need and what the patient need is this, of course, to create the stabilization. However, tic-tac, tic-tac. As soon as you have the balloon in place, the clock starts to tick. We know that you have 30 minutes at the very most if you want to put it in zone 2. So please time it and remember to ask, how many minutes have I had the balloon up? Now, where do we puncture? We've heard that you do it safely in the femoral in most cases, but as the sheaths have diminished in size, it is likely that we will use a brachial approach much more frequently in the future. First option, second option. And we have a couple of other options, as we've heard. Now, one good thing about